Welcome to CFRI's Cystic Fibrosis Community Voices, a video podcast series created by and for the cystic fibrosis community.
Hello, and welcome to CFRI's CF Community Voices podcast series. I'm Siri Vaith, Executive Director of Cystic Fibrosis Research Incorporated, CFRI, and it is my pleasure and honor to introduce tonight's presentation by Dr. Vinayak Jha, Sticks and Stones, Healthy Bones and CF. Dr. Jha is a physician of pulmonary and critical care medicine at the Adult CF Center at California Pacific Medical Center in San Francisco, California. We are in the midst, as this is being filmed, we are in the midst of the COVID-19 crisis, and so our podcast is being recorded from remote locations. And of course, we're all preoccupied with this pandemic and its impact on our lives. But the truth is, all the issues, the many issues related to CF health must still be addressed, including bone health. I want to thank our generous sponsors of this podcast series that make it possible, and those include Vertex Pharmaceuticals, Gilead Sciences, Genentech, and Chiesi USA. And as always, I must remind you that no information presented tonight should be used for your self-diagnosis or treatment, and that any changes in your medical regimen should be cleared first with your CF care team. For those of you who are watching this live via Facebook Live, if you have any questions, please let us know and we'll incorporate them at the end of Dr. Jha's presentation in the Q&A session. So with that, it is my honor to introduce Dr. Jha, and I will turn it over to you. Thank you.
Thank you so much, Siri, and thanks for inviting me to be a part of the podcast series. I really appreciate it. As you said, I'm one of the CF docs in our Adult CF Center. I hope everyone watching is well and sheltering safely in place. My topic today is about bone health, and so I hope that'll allow you to kind of think about something else other than the pandemic. I hope that it is informative for everyone watching. So bone health is a topic that it's not one that gets the most attention. I became especially interested in the topic when one of our adult CF patients in their 20s developed a fragility fracture, and when they had a DEXA scan, was found to have low bone density. Our patient needed to be treated with bisphosphonate pills to help strengthen the bones, and I'll explain a lot of these in the talk. So that was enough. The fact that a young patient had a fragility fracture and needed to go on bisphosphonate treatment, that was enough to convince me that bone health in CF is a topic worth reviewing. And today I want to share with you what people with CF and their family members should know about keeping your bones healthy and strong. I have no conflicts of interest related to this topic. Next slide. And my outline is pretty simple for the talk. I'll be discussing normal bone, including bone's structure and briefly the bone metabolism, as well as abnormal bone. Why is it that some people with cystic fibrosis develop bone disease or thinned bones? How do we assess the bone strength in anyone and in CF patients? And I'll talk about DEXA scans and how to understand them. And finally, we'll talk about ways to improve bone health. And I'll spend some time talking about exercise, about vitamin D, and about bisphosphonate medications. So that's my outline. Let's start by talking about normal bone. Before you are 4 views of the male human skeleton. Your adult skeleton contains a total of 206 named bones. And there are 4 general categories of bones. The long bones in the arms and the legs. The short bones, including, for example, the carpal bones in the wrist. Flat bones, including the skull, the sternum, scapula, and ribs. And finally, irregular bones, including the vertebrae and the sacrum. Our bones serve a variety of functions. They provide a scaffold, a structure for the body. They allow movement by providing levers for our muscles. They protect vital internal organs. They provide the environment for new blood cells to grow within the marrow spaces. Your bones are made of collagen fiber manufactured in your body, as well as calcium and phosphorus taken in through your diet. Calcium is the most abundant mineral in the human body, and 99% of that calcium is in your bones and your teeth. Phosphorus is the second most abundant mineral. About 85% of it is in your bones. Most of the rest of it is in your muscles. Now, when you look at these pictures of a skeleton, you might think that bones are dead, like the hair on your head or on your skin. But that's actually not true. Our bones are living, metabolically active structures. In this diagram of a long bone, you can see it at the top of the picture there, the spongy bone at the ends of the bone. On the outside is the denser, compact bone. But what I really want you to notice are the nutrient arteries supplying the bone. And that's because the bone needs a blood supply like any living tissue needs a blood supply. Each bone in our body constantly undergoes remodeling, starting before we are born and continuing throughout life. Remodeling allows old bone to be resorbed and new bone to be formed. And in this way, the bone can repair microfractures and really keep renewing throughout our life. In fact, most of an adult skeleton is totally replaced by new bone about every 10 years. So the diagram before you shows the two main types of cells which are responsible for remodeling bone. The osteoclasts, shown here in red, and osteoblasts, shown as rounded light green cells. The osteoclasts, with their characteristic ruffled border, that's the border where they meet the bone, they secrete acid, which helps mobilize the mineral in bone, and enzymes, which help digest the organic matrix of bone. And this process whereby they break down an area of bone takes the osteoclasts about 2 to 4 weeks. Following that, the osteoblasts move in and lay down new bone by producing new collagen matrix and by managing the deposition of calcium and phosphate, which are the main minerals of bone. This graph shows a typical woman's bone mass and how it changes over her lifetime. So you can see on the x-axis, the lower axis at the bottom of your screen, the years, and you can see the y-axis is labeled bone mass. So if you can imagine, the figure is showing the total bone mass in the body. You can see it peaks in around the mid to late 20s. Okay, that's when we have the highest bone mass during our lifetime. And it does go downhill after that in all of us. I'd ask you to notice that our childhood and teenage years are a time of active growth. And that's a crucial and valuable time for building up the greatest amount of bone mass possible. In fact, up to 90% of our peak mass is acquired by age 18 in women and age 20 in men. And even after that, the bone mass keeps increasing a bit until our mid to late 20s, at which point it's reached its peak. There's different factors which affect the peak bone mass. And I want to list a few of those for you. One is whether you are male or female, okay? The peak bone mass tends to be higher in men than in women. Number two, race. For example, African American females tend to achieve a higher peak bone mass than Caucasian females. And these differences are apparent even in childhood. Three, there are hormonal influences. For example, estrogen. It's known that women who had their first menstrual cycle, who entered puberty at an early age, often have a higher bone density. And I'll show you some more information on the next slide about that. Number four, nutrition. Having adequate calcium, especially early in life as a child, is important for bone health. And calcium deficiencies in young people can result in significant differences in bone mass later in life. Exercise. Boys, girls, and young adults who exercise regularly generally achieve a greater bone mass than those who don't. So this is an example of hormonal influences on bone density. This study from the Journal of Pediatrics looked at whether the age at which puberty starts has an effect on the bone density once someone reaches adulthood. And it was a multi-center study of about 160 healthy girls and boys. The findings in the study are shown there before you. For girls, it's shown in part A on your left, and for boys, it's shown in part B. And really, the findings were the same for both girls and boys. On the x-axis, you'll see age from 8 to 13 for the girls. And on the y-axis is the peak bone mineral density, meaning the peak bone density. And you can see for girls that in this study, they began puberty, the age of onset of puberty was about 10.7 years old on average. But if girls began puberty a year earlier, they achieved a 2.5% higher bone density. And if girls started puberty a year later than 10.7, then their bone density was about 2.5% less. Okay, so it definitely has an impact in both boys and girls as to the age that puberty starts. Now, this is not an argument or an implication that earlier puberty is better, because earlier puberty has its own separate issues other than bone health. But this is merely an observation that the age of onset of puberty does impact the bone mass. So the key points I covered so far about normal bone is that your bone is made up of collagen as well as calcium and phosphorus. Our bones are living structures, not dead. Our bones are living structures that remodel throughout our lives. Osteoclasts, those cells with the ruffled border, are the ones which break down bone. And osteoblasts lay down new bone. And our peak bone mass After a period of great growth in childhood, our peak bone mass occurs in the mid to late 20s. Let's look ahead at abnormal bone now. Let's talk about abnormal bone. On your left is an example of normal bone. Normal bones are strong and likely to withstand stress. On your right is an example of osteoporotic bone. The word means porous bone. And you can just see visually that osteoporotic bone is thinner. It has a lower bone density, and it is worse quality bone. That is, it's more likely to have a fragility fracture, which means osteoporotic bones are more likely to break from a stress that would not have caused a normal bone to break. So what about in cystic fibrosis? Is there evidence of lower bone density in individuals with CF? And is there evidence of more fractures in individuals with CF? The answer is yes to both. In this study before you, from the University of North Carolina at Chapel Hill, from more than 20 years ago, the bone health, the information about bone from 70 adults with CF who were referred for lung transplant was studied. Now, since you know that these 70 patients were referred for lung transplant, you know that they had pretty severe lung involvement. Their bone density was found to be 2 standard deviations below the normal population. Okay, so much lower than the normal population. And fractures were twice as common in this group as in the general population. There was also more kyphosis, which is curvature of the spine, and there was a shorter stature by about 2.5 inches, probably due to vertebral compression fractures. This is a more recent review from 2010, and this was a meta-analysis. So the authors pooled the information from 12 studies, about 1,000 patients in all. And the goal was to determine how common is osteopenia, which is thinned bone, but not overtly thin enough to be called osteoporosis. How common is osteopenia? How common is osteoporosis? And how common are fractures in CF patients, people with CF? And the median age, I want to point out, of these patients was 28 years. So remember back to the other slide, the mid to late 20s is the time when our peak, that's the time of our peak bone mass. So our bone density should be expected to be the greatest that it's going to be for our lifetime. And yet, in this pooled group of patients, almost 25% had osteoporosis, almost 38% had osteopenia, which remember is a little, is not as severe as osteoporosis, but thinned bone. 14% had vertebral fractures, and 20% had a non-vertebral fracture, so quite high figures. One thing to point out here is that not all of these fractures were patient-reported. In other words, some of these fractures were just seen on the x-rays, and the patient may not have even known that they had them. So in one sense, it's good news because they weren't causing enough symptoms for the patient to have noticed them. But on the other hand, you do see that there's bone disease here causing these fractures to occur. So collectively, we call this CF bone disease or CF-related bone disease. So what causes some individuals with CF to develop these problems in their bones? Why does this happen in some people? So I listed several of the most common and important causes before you, and I just want to mention each of these. First, vitamin D deficiency. Various studies have shown that vitamin D levels are lower in people with CF, and this is probably due to malabsorption of the vitamin D, because we know as a fat-soluble vitamin, if someone has if someone has pancreatic insufficiency, they have trouble absorbing fat, and therefore they have trouble absorbing the vitamin D. 2, infection and inflammation. Pulmonary exacerbations, CF exacerbations, especially repeated exacerbations, and the inflammation which occurs during those times, that has been shown to increase bone resorption, contributing to thinning of the bones. Malnutrition. If malnutrition is present, it contributes. And there are studies, various studies showing a correlation between low BMI and low bone density. 4, lack of exercise. Now, this may happen due to the lower lung function in some people with CF, such that they just find it harder to breathe or harder to exercise. Or it may happen due to the time, simply the time needed for some people to complete their CF treatments, like nebulizers and antibiotics. But nevertheless, if there is a lack of exercise, then that contributes to bones that are thinner. Okay. 5, corticosteroid use, including prednisone for ABPA, contributes to bone thinning. And that happens in people with CF and in people who do not have CF as well. 6, delayed puberty. You already saw on the prior slide that how later puberty usually means a slightly lower bone density. And it is known that some children with CF have a slightly later onset of puberty. And finally, dysfunction in the CF transmembrane regulator. So dysfunction of the CFTR molecule itself, even putting all the other factors aside, it may contribute to CF bone disease. Okay, so these are the various factors that are involved. How do we detect thinning bones? How do we detect when there's a problem? So the answer is getting a DEXA scan, which I imagine if you are an adult with CF yourself and you're watching, you probably have gotten a DEXA scan yourself. And if you're a parent of someone with CF who's younger than 18, you may like to know about it. So the DEXA scan is really just a X-ray, just kind of a fancy X-ray, and you can see this patient lying on the table is being positioned for her DEXA scan. The X-ray energy is generated below her, below the table, and it is detected at the shelf above her. So DEXA scans are recommended for all adults with CF, really starting at age 18. And in those children more than 8 years old who have certain risk factors, and I'll just list those briefly. So children older than age 8, if they are underweight or their lung function is less than 50% of predicted, or they're on steroids more than 5 milligrams a day of prednisone, or there is a history of delayed puberty, or if they have already had a fracture. So any one of those 5 risk factors in a child older than 8 would mean they should have a DEXA scan, okay? For adults with a DEXA scan, If your results check out fine, and we'll go through what that means, then you wouldn't need to have one again for 5 years. So just in terms of the DEXA, it's very, very low radiation. In fact, if you fly from New York to San Francisco round trip after the COVID pandemic is over, you would actually receive 10 to 15 times as much radiation just from being in that round trip flight as you would getting a single DEXA scan. So they're much less radiation even than a round trip flight. Takes about 15 minutes, no needles, no IV. One thing to note is that it's best to get tested on the same machine if you are able to. So if you had a DEXA scan 5 years ago and you're due to have a DEXA again and you're living in the same area, it's important to try to go back to the same facility, the same radiology facility to get the DEXA, because different manufacturers have slightly different calibrations and may provide slightly different results. Next slide. These are examples of the images from the two most commonly scanned locations. And on your left, you see the proximal femur. So that is the top of the thigh bone where it meets the pelvis. And on your right is the lower spine, the lumbar spine. And in fact, all 5 of the lumbar vertebrae are seen there, but the technologist has outlined 4 of them. So L1 through L4 are the 1st through 4th lumbar vertebrae. And from these images, the computer can calculate your bone mineral density. And you'll see that on your DEXA report, but you'll also see a score, which is like a grade for your bone density. And I want to talk about that score. What you'll see on the report is both a T-score, that's T as in tango, and a Z-score, that's Z as in zebra. Now, the T-score is the one to pay most attention to, especially for adults. I'll say a bit about the Z as in zebra score in a minute, but the T-score is the one that's most important for adults. The T-score compares your measured density with someone, a healthy 30-year-old of the same sex. So for example, if you're a 40-year-old woman, the T-score will compare your bone density to a healthy 30-year-old woman. Okay? Higher scores are better and mean higher bone density. Lower scores mean lower bone density. So you can look to see there on this ruler, the normal, what's considered normal, goes from -1, a T-score of -1, and on up higher than that. And for example, 0 means that you had exactly the same bone density as a 30-year-old. And if you had thicker bones, meaning higher bone density, you may get a +1 or +2. So if your bone density is less than -1, then you're either in the osteopenic or low bone density, was shown here in yellow, -1 to -2.5. Or if it's below -2.5, that's considered osteoporosis. So T-score less than -2.5 qualifies as osteoporosis. And I just want to say a bit about the Z-score again. Z as in zebra, that's most applicable in the younger than 18 population. So I don't want to focus on that for this talk, but you can certainly get an explanation from your CFP. So if you get your DEXA scan done and your T-score is higher, greater than -1, great. Then really all you have to do is keep doing what you've been doing, taking your supplements, including the vitamin D, calcium, vitamin K, and others, maintaining a healthy body weight, continuing exercise, and then it would be repeated in 5 years. But what if you're actually found to have low bone density? What if everything's not perfect and you're found to have either low bone density or frank osteoporosis. Then what? So then your CF team will discuss this with you, and they'll address all the possible causes which I mentioned before, including how are you doing with your nutrition? How are you doing in terms of treating pulmonary infections, and are those being managed appropriately? How are you doing in terms of prednisone use? And if you are on prednisone, can the dose be lowered or tapered off? So they will consider all these things with you. They will also consider and talk to you about how are you doing on vitamin D levels and your calcium intake, exercise, and they may talk to you about bisphosphonate treatments. So that's what I want to spend the second half of the talk talking about is exercise, vitamin D, and the bisphosphonate medications at the end. So let's talk now about vitamin D. Vitamin D is key for bone health. And I'd like to tell you something about its metabolism. Vitamin D is actually made in our skin through getting exposed to sunlight. It's also ingested in your vitamin D vitamins and supplements. Very few foods actually naturally contain vitamin D, but if you've seen in the grocery store, etc., milk, infant formula, and other foods do have it added in order to prevent vitamin D deficiency in the general population. So once it is made in your skin or ingested, it first has to be activated in the liver, and then that molecule has to be activated in the kidney. It has to go through those two steps. And finally, that active molecule, 1,25-hydroxy vitamin D, its key role is to make sure that enough calcium is being absorbed from your intestine. Enough calcium is being absorbed from the food that you're taking in. Unfortunately, several studies have shown in the past the vitamin D levels in CF patients were low. And I don't want to spend too much time on these details, but again, the most important action of vitamin D is to increase the amount of calcium that gets absorbed from the gut, from the intestine. If vitamin D is low, then not enough calcium gets absorbed from the intestine. Not enough calcium gets absorbed, then the calcium level in the blood falls, and parathyroid hormone ramps up. The action of parathyroid hormone is to cause the bone to actually be broken down in order that the calcium from that be obtained and be added to the blood. So if vitamin D is too low, the downstream effect is bone gets thin in order to release the calcium from the bone. And this talk is all about keeping bones strong. So you can see why it's important to keep the vitamin D levels within the proper range. So really for all people with CF, the recommendation is to measure the vitamin D level every year. It should be measured at the end of winter. And the reason is because winter is the time when you get the least sun. And so that would be the time, the winter would be the time when your skin would be expected to make the least vitamin D out of the whole year. So you know, if you get your D level measured in the end of winter, if it's adequate and good at that time, you know that it's adequate and good throughout the whole year. What's a healthy level? About 30 to 50, okay, per the CF Foundation. If the level is low and your CF team puts you on higher supplements, then they're going to ask you to recheck it in 3 months. And the supplement that they're probably going to ask you to take is vitamin D3, cholecalciferol, because that is the form that's recommended by the CF Foundation. So this is just a reminder, this character from Game of Thrones is reminding us to get the vitamin D measured yearly when winter is over. So, and what dose of vitamin D3 should we be taking? For CF, the standard dose that's recommended is 800 to 2,000 international units per day. If your level is measured and it's slightly low, meaning below 30, but greater than 20, then that dosing will be doubled or tripled, as you can see there. If your level is moderately or severely low, less than 20, then your team will probably ask you to take 10,000 units per day. And again, it'll be checked again in 12 weeks. An alternate dosing regimen that's sometimes used is 50,000 international units per week, right, to 12 weeks, and then get your level rechecked. Let's talk about exercise for a minute. Exercise helps your bones and helps so much in your body, including your heart and your muscles and your mood. But exercise helps bones specifically because the stress of bearing weight and being physically active actually leads to increased bone formation by osteoblasts. So that's why it's recommended that you do either weight-bearing exercises or resistance exercises. And it really doesn't matter if it's high impact or low impact. A lot of things are included in this, including weightlifting as shown, but it could be just jogging or fast walking, sports, stair climbing, jumping rope, dancing. In terms of resistance exercises, it can include the elastic exercise bands. So really anything that causes the bones to feel that normal stress. I want to show you how exercise even helps our astronauts. So 220 miles above the Earth's surface, the International Space Station is flying, and the station, its crew, and all the objects on board the station are falling around the Earth. So it's actually kind of a misnomer that there's not gravity up there. There certainly is gravity, which is why the moon keeps going around. But the reason that that people are floating is because they're in free fall. Okay, so they're free falling around the Earth. And in fact, you can see one of the astronauts in the picture floating. So because of this situation, the bones of astronauts do not experience the same gravitational load that they do here on Earth. It's different in space. And the result is actually increased bone resorption and possibly also less bone formation. So an astronaut who goes and spends 6 months on the space station could end up losing 10% of the bone mass in their femur, which is quite a lot. So they could end up losing that if they don't do something about it, if they don't do something to counteract it. And what do they do to counteract it? They exercise. So exercise can counteract bone loss. This photo shows an astronaut on the International Space Station, and she's using something called the Advanced Resistive Exercise Device, the ARED. It's basically just a fancy resistance machine because regular weights are not going to work because of free fall. So this is a fancy resistance machine, and astronauts are assigned a serious workout regimen of 2.5 hours a day for 6 days a week. And that has been shown to help prevent the bone loss that happens in microgravity. The good news is you don't need to exercise 2.5 hours a day here on Earth and six days a week. You just need to do exercise. It's proven to work for astronauts, and it'll work for you too and help maintaining your bone health. So let's talk a little bit about bisphosphonate medications. Now these are, I mentioned at the beginning of the talk that one of our patients had to go on Oral bisphosphonates due to having a fragility fracture or low bone density. You can see the chemical formulas before you. At the top left is inorganic pyrophosphate. The bisphosphonate medications are analogs of inorganic pyrophosphate. And so you can see that they have at the top right, they have a carbon phosphorus nucleus, and they have two side chains labeled with the red and blue. So the R1 lateral chain is responsible for anchoring the drug in the bone matrix. Whereas the R2 lateral chain is the one that has the biologic and medicinal properties. And so 4 of the bisphosphonates are shown there before you: alendronate, risedronate, ibandronate, and zoledronate. The zoledronic acid, which has the brand name Reclast, has both the highest affinity for bone and has the most potent ability to inhibit a key enzyme. The way bisphosphonates help the bones increase their bone density is by counteracting osteoclasts. Remember, those are the cells with the ruffled border shown in this figure in light blue. What happens is that bisphosphonates are in the bone matrix, okay, again, by that R1 lateral chain, and the molecules get taken up by osteoclasts during their process of bone resorption. But once taken up, the osteoclasts once taken up, the bisphosphonates cause the osteoclasts to lose their ruffled border and their normal structure. And so they no longer function as well. And the result of this is that overall bone resorption is cut, it's decreased. And the medications may also exert some effect on osteoblasts, but I'm not focusing on that for today's talk. These are some of the regimens which, if needed, your CF team may put you on. And the first 2 are oral, alendronate and risedronate, are once weekly oral medications. The oral medications have low absorption, so they have to be taken on an empty stomach, with a full glass of water and 30 to 45 minutes before eating anything else. And even with all these practices and cautions, only a small portion of each single dose reaches the bone matrix. The last 3 forms are IV, and you can see that a couple are need to be given every 3 months, and zoledronate can be given yearly if needed, but only for 3 doses in general. What have these medications actually been shown to do for the bones? Let's look at the evidence on the next slide. So I've shown you here a table with the duration of certain studies, and this table is from the Cochrane Review 2014. It shows in the first column the time in months, the duration of the studies, the parameter that was examined, and for most of those, almost all of those, it's bone density, the location in the body, and then the result. So what you're seeing here is that in the first row, fracture, an improvement in fracture rates has actually not been shown for bisphosphonates in people with CF. Okay, what has been shown for people in CF is the bottom 6 rows, meaning the bisphosphonates do improve bone density. And you can see that there, I've highlighted in yellow, they increase the bone density by about 4 to 6%. Okay? But due to either the duration of the studies being too short or due to perhaps the number of people included, a reduction in fractures, which is what we really care about, has not been demonstrated. However, I want to reassure you that a reduction in fracture has been shown in a different population, okay? The postmenopausal women with osteoporosis, reduction in fractures have definitely been shown in that population. And so their benefit for people with CF is extrapolated from other populations. And this slide and the next are my last two substantive slides. This is a little technical, but I wanted to include it because it gets to the modulators and what effect the CFTR modulators may have on bone health. So if you look at this figure before you, it shows the large circle is an osteoclast with its ruffled border sitting on a piece of bone. But I'd like to draw your attention to the circle in red there, and the rankle. So rankle is a membrane protein which is actually expressed on osteoblasts. So the rankle protein sits on osteoblasts, and when it binds, when the rankle protein binds to its receptor, then that binding initiates processes which lead to basically more osteoclasts being formed. And osteoclasts, as we know, cause bone resorption. So this membrane protein, the rankle, on osteoblasts, when it binds, it leads to more osteoclasts, ultimately leading to bone resorption. And when we're trying to protect bone, we don't want too much bone resorption, and so you wouldn't want too much rankle being produced. So in the next slide, I'll show results from a study in which an analog of lumacaftor, C18 is an analog of lumacaftor, this was added to cultured osteoblast cells from 5 CF patients who were homozygous for the F508del mutation. So here you see the results. Remember that lumacaftor is one of the 2 medications in Orkambi, lumacaftor, ivacaftor. So in the first column, what you see is the control group, and I should just point out the y-axis is the relative production of the rankle protein. And again, to protect bones, we don't want too much rankle around. We don't want too much rankle being produced. So in the first column, the control group, that's 1, that's the control group. In the second column, the investigators, again, these are cultured osteoblast cells. The investigators added TNF-alpha, which is a cytokine which stimulates inflammation that might occur, for example, in infection. So the TNF-alpha, you can see, caused the amount of rankle to go higher. And remember, we talked about how cycles of infection can contribute to thinning of the bones. In the third column, you see C18 added. Now, C18, you could say, is analogous for lumacaftor, which is the CFTR modulator. So when C18, the lumacaftor-like molecule, was added, you can see the amount of rankle went down. And then finally, in the last column, when TNF-alpha, which causes inflammation, was added, but the lumacaftor-like molecule was also added, you can see that the amount of rankle was lower. It did not go up like it did before. So the bottom line of this slide is there is reason to believe that the CFTR modulators might have a direct beneficial effect on bone density. Of course, more studies need to be done, and we, along with other people, are interested in doing those studies. So I'd like to just give the summary slide to let you know some of the take-home points, the most important points that I hope you remember. Bones are living, active tissues which remodel throughout our lives. Osteopenia, which is low bone density, and frank osteoporosis are defined based on the bone mineral density as measured by a DEXA scan. CF bone disease has several causes and can result in fragility fractures. Calcium, vitamin D, K, and exercise are all important. But if needed, bisphosphonate medications, whether oral or IV, are proven to increase bone density. Well, thank you for your attention today. I really want to thank Siri Vaith and CFRI for inviting me to be able to give this talk and talk about bone health. I also wanted to thank people who gave me advice on an earlier version of the talk last year, Dr. Chidwani and Kashif Jaffrey, CPMC. And I want to thank my partners in our CF clinic, Ryan Doherty, Carolyn Hrushka, part of our CF team. So next slide. Thank you again. And I'd be interested to hear if people have questions.
Thank you so much, Dr. Jha, for that amazing presentation. I learned quite a bit. I don't know if there are questions on Facebook. I will tell you that during your presentation, I was receiving texts from people who are question shy on Facebook. They don't want their name there. So they were texting me asking to be the communicator. So I do have some questions for you. One person said, while you were talking, I went online and looked up my T-scores.
Okay.
And what I saw was there were many numbers that vary based on the part of my spine, from -1 to -3. So would the treatment focus be basically geared towards that worst number?
Yes.
Or how is that decision made?
Yes, thank you for that. That's it's a detail that I left out, but that's a key feature in understanding your DEXA report. So yes, the three areas which are most commonly imaged are the lumbar spine, the proximal femur, and what's called the total hip. So usually those are the three most common areas, and you get 3 scores. And so your team and what's common practice, your team will act based on the lowest score out of those 3, meaning the most negative score. So I think I heard there was a -3.
Mm-hmm.
I would also, wonder what is the age of the person, because again, the T-score should be used really for adults.
Mm-hmm. I actually know this person that texted me.
Okay,
in
okay.
Mid-20s.
Okay, so yeah, so the T-score is applicable, and so yes, the T-score of -3, the lowest number there, would be the one to trigger, a diagnosis of osteoporosis.
Got it. Thank you.
We have another question from Facebook. Have there been improvements in vitamin D absorption for those using CFTR modulators?
That's a good question. I don't know the answer to that, but it's an excellent question, and there's definitely reason to think there would be. In other words, there's definitely biological plausibility, because we have certainly heard, I've certainly heard anecdotally about improvements in various GI facets and features, various GI symptoms with the modulators. And so that specific, question about whether there's been improvements in vitamin D absorption, I don't know the answer. I don't know if it's been studied, but I would say that there is, biological plausibility to think that could happen.
That would be fascinating to study, because everybody talks about, gaining the trikafta 15, and all this
Yes.
gain. So that indicates absorption, right? So
Yes. Yes.
Somebody studies that.
Yeah, I think it's a good topic.
Another question is, you mentioned several different types of therapies. How do I know, or how does my care provider know which one to prescribe?
The choice has to be individualized. So it's gonna be depend on your specific circumstances. But that being said, I could give some broad, approaches to that question. One is, my first approach would be taking a pill is easier and more, accessible than having to go in and get an IV treatment. So, and it's also less expensive. So if you can take something at home successfully and not have to go in and take an IV medicine, then that would be kind of desirable. It may happen though that people are not tolerating the oral medication for one reason or another, maybe due to GI upset, etc. Or maybe you're tried on it and for whatever reason you're not tolerating it. And so then your team may say, you know what, maybe it's better to go to the IV form, which we know you're not going to have those GI tolerability issues. Sometimes bone pain with the IV forms can be more of an issue. So that's kind of a downside of the IV forms. But that would be the general approach. A pill would be easier. And if you can tolerate it, a pill would be usually first line. But for example, in transplant patients, they're often given a dose of the IV zoledronate in their transplant admission, at the end of their admission before they leave. So that would be the way that's dealt with for them, because they're definitely at risk for bone thinning.
Because of the high dose of steroids and immunosuppressants.
Yes.
Right. And from what you mentioned, so GI upset seems to be the most common complaint for people who do use the oral version.
Yes.
Got it. Okay. I don't want to keep going here. Are there more questions from Facebook?
We have one more question from Nancy. My almost 13-year-old daughter has constant pain in her ankles, knees, and hips. What could be causing this to happen? We were told she has thinning of the bone in her right hip, but I'm not clear what this means.
I would first say, I don't think I can know exactly what's causing the pain, but if I believe you said she's been told that she has thinning of the bone, then I would say, well, she should talk to her team about what does the DEXA show. In other words, what are the numbers? What are her scores? I don't, in what I've read and in my experience, it's not classic for the thinning to, present as pain. I think it could in a small proportion of people, or there may be some other cause. So I don't want to speculate actually on the cause of the pain, but I would say you should discuss her Z scores, Z as in zebra, and see where she is on those.
Unmute there. Two more questions. One came in, as more women with cystic fibrosis reach menopause, will biophosphonates become a standard part of clinical care?
I think so, yes. I mean, in a word, yes, I think, because it's already for postmenopausal women, it's already not uncommon to be on a bisphosphonate. And in fact, that's the population, the postmenopausal woman and older men, but I think the majority is postmenopausal women. That's the biggest population who are on bisphosphonates. And so, yes, as more women with CF reach menopause, I think it will be common or not uncommon to see them on it. Especially given you've seen some of the figures about the prevalence of low bone density, etc. So I think that it will be used often.
And then let's see. one more about the absorption of the vitamin D. Um, do I need to take my calcium and vitamin D supplements with food and enzymes to assist with absorption?
You know, that's a great question. I actually do not know. I would defer that question to our nutritionist or dietitian on the team. I don't know if they should, what they should be taken with.
Got it. Okay. Well, now people have a list of questions for their next clinic visit.
Yes, and I have something to ask Elena in our group.
Yeah, there we go. Well, Dr. Jha, we are so grateful to you for sharing your time and your expertise during what is a very insane time for all of us. And this is a true gift to the CF community. And thank you so much for participating.
Thank you very much for having me and having me be a part of it.